Hi everyone, my name is Nassaratou Diaby and I'm going to present to you guys the implementation of evidence-based smoking cessation guidelines. My chairperson is Dr. Jennifer Guen, the second reader is Dr. Maria Snell, and my community member is Dr. Igiezo. On this slide, we will talk about the purpose of this DNP project, which was to evaluate the provider's self-efficacy, to implement smoking cessation guidelines, and to improve mental health patient smoking outcomes. Like I said, the purpose of this DNP scholarly project was to evaluate if healthcare providers increase their self-efficacy to address smoking cessation in patients with mental health disorders with implementation of evidence-based tobacco cessation guidelines compared to the standard practice with no guidelines. How significant is tobacco smoking? It is a major cause of avoidable illnesses and death. Lack of proper smoking assessment, need for knowledge among the clinician. The need for knowledge among the clinician is central. The level of nurse knowledge and knowing determines the overall patient outcome. The application of an evidence-based smoking cessation guidelines is the epicenter of determining the nature of patient outcome anticipated in 3 months at this facility. Concerning this aspect, the need for knowledge among the clinician becomes central in the determination of the level of quality of this project. Therefore, proper assessments of the ways of advanced nurse practitioner understanding becomes a priority in this case. The fundamental nursing pattern of knowing becomes handy in the implementation of this process. Tobacco smoking is associated with congenital disabilities, various health problems, limitation of physical and daily activities, there is a sleep deprivation, adherence to the guideline improves patient outcome. Tobacco smoking has been associated, like I said, with congenital disability in mothers who smoke during pregnancy. It can predispose an individual to tuberculosis, to low libido, sleep deprivation, and malignancy. The clinical practice guidelines are generally regarded as the gold standard in tobacco cessation management. The review of the literature revealed that smoking cessation guidelines improve patient outcome. Smoking cessation reduces complications associated with smoking. Nurses and physicians are the patient advocates. The common theme identified was the 5A's smoking cessation model. Like I said, the common theme identified among the various articles reviewed was related to the evidence-based smoking cessation intervention called the 5A smoking cessation model. The 5A model comprises 5 interventions, which are asking, advising, assisting, arranging, and assessing. The literature review contributed to the evidence that evidence-based treatment guidelines resulted in higher compliance of the healthcare service providers to engage in tobacco cessation advice by enhancing the healthcare staff self-efficacy and application of evidence-based smoking cessation guidelines. In the literature review, it was discovered that positive healthcare outcomes minimize the patient healthcare costs. Adherence to evidence-based guidelines demonstrated a definitive change in behavior. The efficacy of evidence-based guidelines enhances healthcare staff self-efficacy. There is more training that is needed to alter the behavior of physicians in adhering to the guidelines. The literature review revealed that adherence to evidence-based guidelines demonstrated a definitive change in behavior. On this slide, we will talk about the theoretical framework. The trans-theoretical behavior model, called TTM, is an integrative theory. It assesses the readiness for change. It is a complementary model. The trans-theoretical behavior model was developed from smoking cessation research. It attempted to include various constructs such as levels and processes concerning change, benefits and drawbacks of change, and self-efficacy. The trans-theoretical model is a complementary model for comprehending how individuals and the general population work toward accepting and managing health behavior change for positive outcomes. The trans-theoretical behavior model is divided into 5 stages. The pre-contemplation stage is the initial stage where individuals do not anticipate taking any action heading to the future, usually denoted in 6 months. For a smoker, the individual has no intention to quit smoking behavior. The individual has never thought of quitting and has never also considered any adverse effect associated with smoking. The contemplation stage is when an individual contemplates with changing in the coming 6 months. Many smokers at this stage belong to this stage since it involves a lot of time brainstorming on whether to adopt a change or persist with a custom practice. During the preparation stage, individuals tend to adopt an action soon, usually denoted in a month. Concerning smokers, this might constitute mental readiness about quitting. In the action stage, individuals have settled on certain overt modification in their way of life within half a year. During this stage, smokers reduce the number of cigarettes or adopt low-tar and low-nicotine cigarettes. In the maintenance stage, individuals have adopted the overt action in their lives and are positively working to inhibit any relapse episodes happening. In this stage, smokers try to maintain the change practice and integrate the current practice as a healthy lifestyle. What is the impact of a trans-theoretical model? Smokers need help to stop. Addiction takes time to conquer. The trans-theoretical model moves the smoker from one stage to another. It improves effectiveness of behavior change intervention. When the trans-theoretical model is employed in the tobacco cessation scenario, the aim is to move the smoker from one stage to another. It is perceived as a moderate development that takes considerable time, and individuals typically do not overlook any program. This project was conducted at an outpatient behavioral clinic. No previous smoking cessation guidelines existed. I used the exploratory retrospective design, use of the 5A algorithm. The post-implementation data was collected, and the reason for this was to assess provider self-efficacy and patient outcome. A quantitative design was employed in this project, particularly an exploratory retrospective design. Participants were not engaged due to the retrospective nature of the project. In October 2020, a private outpatient behavioral clinic adopted the 5A smoking cessation strategy. The clinic manager provided a written list of patients who received care 4 months post-implementation of the 5A algorithm. Data were collected from an electronic medical records named EMRs. "30 electronic medical records were collected. It comprised the EMR of patient 18 years or older, EMR with ICD-10 code F31.9 bipolar, schizophrenia, and schizoaffective disorder were included. Documentation of patients seen between October and September 2020 was collected. 30 charts were audited after healthcare workers' education on the utilization of the 5A algorithm. The inclusion criteria consisted of patients 18 years or older, patients with bipolar, schizophrenia, and schizoaffective disorders. Patients seen at the clinic for greater than 1 month. The exclusion criteria include a patient below the age of 18 and above the age of 80 years old. Patients with an ICD code diagnosis other than bipolar, schizophrenia, and schizoaffective were excluded. Patients who have been at the facility for less than 1 month were not included. No patient identifier were included in the data collection process. The data analysis consisted of using the logistic regression, proportion z-test, the chi-square test, and the chi model. All tests demonstrated no significant difference between proportion because high level of non-adherence by providers on the guideline for educational was noted. The 5A algorithm in making decision was poor, corresponding with a p greater than 0.05. Some issues in the medication-only strategy had been observed as well, causing it to be excluded in the comparison. The chi model also failed to work because the predictor variables were not significantly associated with smoking cessation at the significance of 5%. The high positive cessation outcome in the counseling-only intervention was greater than 0.05, which cannot account for the low dual intervention, medication, and counseling outcome, where we only had 2 patients in that category, making the p greater than 0.05. I audited 30 charts. Male and female with mental illnesses, largely dependent on providers. The result largely depended on providers. High level of non-adherence by providers. The education intervention was p greater than 0.05. The 5A algorithm in making the decision also was found at a p level greater than 0.05. There was no significant difference. 30 participants with a diagnosis of bipolar, schizophrenia, and schizoaffective were included in this project. All elements of the intervention implementation were largely dependent on the participating healthcare providers. The z-test demonstrated no significant difference between proportion because of high levels of non-adherence by providers on the guidelines for educational intervention, where we only had like 7 patients in that category. And the 5A algorithm in making the decision, we only had 8 patients in that category, resulting in a p greater than 0.05. As we continue to look into the results, the medication-only strategy was excluded in the comparison. There was no association between the Pearson chi-square test The Chi model failed to work, as previously mentioned, and it was at a significance of 5%. Although the provider had a possible significant influence on the negative outcome in the strategy implemented, in all three intervention types, some issues in the medication-only strategy had been observed, causing it to be excluded in the comparison, the zeroth value in the column proportion. Overall, this development resulted in outcomes of no association in the Pearson chi-square test and the variable lack of predictive value on smoking cessation in the logistic regression analysis. The Chi model also failed to work because the predictor variable were not significantly associated with smoking cessation at the significance of 5%. As we can see in this table right here, the educational intervention, which was mainly guided by the provider adherence, we only had 7 patients were included and 7 patients were not included. The algorithm followed in the decision making, we see that only 6 patients were included in that category. In the strategy implemented, in the counseling, we only had 1. In medication, we only had 2 patients. And in medication and counseling, we only had 4. The limitation of this project was the sample size by itself. Only 30 patients were reviewed. The limited setting, the provider non-adherence, and the lack of generalization. The result of the study was limited to the outpatient behavioral center. The number of participants, N30, was not enough to generalize the result of the study. Therefore, it served as a limitation to the result. The finding of the project did not support available evidence in previous studies. Previous studies and evidence-based practice unfold that increasing practitioners' self-efficacy increases patient outcome, quality of care, and safety. On this slide, we will look at the discussion. There is a need for smoking cessation training, increased awareness of recommended evidence base. Result did not support available evidence, healthcare providers' self-efficacy. The healthcare providers did not demonstrate self-efficacy in adhering to the 5A algorithm. As a result, this limited the skills, resources, time to scrutinize and assess every patient effectively. The participant could have been the wrong choice for the clinical investigating department. The healthcare providers' clinical experience and opinion could have influenced the recommendation. Healthcare providers must improve their self-efficacy by using evidence-based guidelines. What are the implications for practice? Improve provider self-efficacy through training, improve the current gap in knowledge, serve as change agents, awareness on utilization of the 5A algorithm. The Smoking Cessation Project aimed to increase healthcare self-efficacy in treating mentally ill patients who smoke. The results obtained from the data collection demonstrated the need for further healthcare provider coaching regarding addressing smoking cessation during an office visit. This project underscores the lack of healthcare providers' competency in that area and the need for improvements. The project called for an extensive need for training and education to improve the current gap in knowledge in addressing smoking cessation via the utilization of the 5A algorithm. In the conclusion, we can say that there is a need for an ongoing education, increased awareness about smoking cessation, increased knowledge with use of evidence, improve patient outcomes. The DNP program is there to influence healthcare sectors and being aware of a gap in translation of evidence base. The availability of tobacco and lack of policies regulating the utilization of drugs contribute to increase smokers in a healthcare platform. The smoking cessation program was initiated to identify a measure that could reduce dependence on nicotine among mentally ill patients. The utilization of the 5A algorithm failed to improve the outpatient behavioral outcome in healthcare. The program emulated diverse intervention, including counseling and teaching on the implication of the behavior. The program outlined smoking cessation guidelines through the 5A algorithm that could bolster personal awareness and heighten access to cessation resources, including support mechanisms and method for nicotine replacement. Nevertheless, the study showed that the development of a smoking cessation program could not help alleviate the smoking tendency among patients experiencing mental illness at the outpatient clinic. Any question? Thank you for your time. I really do appreciate your constructive feedback. Here is the list of my references. Thank you.